Why don't we get started? Good morning, everybody. Dr. Williams is at a GME meeting, so I'll have the pleasure of introducing our speaker this morning, Dr. Jason Abel. And we're really glad to have him give us a lecture this morning. Just to recap on Dr. Abel, he did his undergrad at University of Texas at Austin, then went down the road to Houston, where he did medical school at UT Houston. From there, he went to the University of Utah for his residency, and then back to Houston for fellowship at MD Anderson Cancer Center, and then joined us here in 2010. So he's been here for about 14 years now. He's quickly ascended the ranks since joining our group here in 2010. He's currently a professor in our department. He holds the Robert and Dolores K. Schnees Chair in Urologic Research. He is the inpatient dyad lead, as well as the head of the section of Urologic Oncology in our SUO Fellowship Director as well. He is a true surgeon scientist and was really recognized by the AUA for his early career accomplishments with the Gold Cystoscope Award. And he continues to really do great things in the urologic oncology world, with really a world expert in urologic oncology with a focus on kidney cancer. And we're really glad to have him give us a talk this morning on small renal masses, choice architecture, and decision making. So thank you, Dr. Abel, for being here, and the podium is yours.
Oh, no. How about that? Can you guys hear me okay? Great. Thank you for the kind introduction. Sorry about my nasally voice. So this morning we're going to talk about small renal masses, and I tried to frame this in the context of behavioral science, choice architecture, and decision making, because I think this really helps. It's helped me understand how patients make decisions, and I think it really helps to make me a better doctor. If you think about kidney cancer in 2024, as residents or anyone learning this, it's really helpful to think of three different stories. So about 20% of patients still present with metastatic disease. And those patients, their median survival is around 24 months in population-based series. About 15% have locally advanced disease. These are the T3 patients, and about half of them progress to metastatic disease. Dr. Shapiro is going to talk about those patients in a few weeks. Today, we're going to talk about localized patients. So patients, it's about 2/3 of patients now. They have a confined to the kidney and a very favorable prognosis. So just a little bit about behavioral science. Start out a little bit. This mind space framework was developed by in the UK by the Cabinet Ministry to look at things that influence people's decision making. So the messenger. So we're heavily influenced by who communicates the information. So this room would be packed today if Taylor Swift was giving a talk on small renal masses, right? And I know Zoe would remember all of this much more than if I'm just saying it. Incentives, right? So as humans, we're very risk averse. We try to avoid losses. And so cancer patients, they don't want to die, right? None of us want to die, but that's what they're thinking when they walk in the room. Norms. We're strongly influenced by what other people do. My father had a prostatectomy. I'm going to have a prostatectomy, right? Defaults. We go with the flow. If I frame something in the context of this is the gold standard treatment, who doesn't want the gold standard treatment, right? People don't want to say, okay, I'm going to go with second best. They want what you put as the default. Salience. Our attention is drawn to something that seems relevant to us. If you don't have a small renal mass, this is a lot less important talk to you. If you do, this is a very important talk to you. Priming. Our acts are influenced by subconscious cues, right? In our society, the word cancer, you hear the C word, you think something terrible is going to happen to you, right? And that's not necessarily true with all cancers. Affect, emotion. So anyone that was alive during the COVID pandemic saw that we make a lot of decisions based on emotion. Those aren't necessarily the best decisions, but it definitely plays a key role. Commitments. We seek to be consistent. with public promises with things we've done in the past. I've had lots of patients say, oh, well, I'm never getting chemotherapy. I saw what it did to my mom. I'm never getting it. And you're like, well, it could still help you. So it's something you have to kind of to pull out of there. And then finally, ego. We act in ways that make us feel better about ourselves. So I don't think I've ever heard a inspirational cancer story told about somebody who made good decisions and didn't get treatment, right? Inspirational cancer stories are always about somebody that fought, action, action, action. So we're predisposed towards action. Social media, you cannot get away from behavioral science. I like this because I binge watch TV sometimes. You look at Netflix, when the episode is loaded automatically, you are much more likely to binge episodes. If they load it faster, you're more likely. If they let you skip the intro, even more likely, right? So anyone that's in Wisconsin in the winter could tell me this just as well. So the idea of choice architecture, Dr. Thaler and Dr. Sunstein in 2009, how choices are presented impacts how your decisions are made. And frequently this is an unintended consequence. Lots of different examples, but how you present a choice to people can help them make the best decision. Sometimes it's hard, and frequently it's hard to know what the best decision is. But one good thing is people want people to walk upstairs rather than go on elevators. So they put the stairs in the front and they put the elevators in the back. You'll also notice that in the MFCB, the elevators in the front, stairs are way in the back, right? So we're not playing with choice architecture in our design at UW. I think it's also really, you have to have an aircraft analogy, right? Because we just have to. But medicine loves aircraft analogies, keeping things simple. Really, I think when you first go out, you want to talk with patients, you want to make it as simple as possible, simulate experiences for them, kind of model different information. So if I do it this way, this might happen. If I do it that way, that might happen. And try to not overload patients with information that's not important. Again, this is kind of the opposite of what we do in medicine. This is the opposite of like the inbox, right? You're not getting just the important information, you're getting everything. But when you're talking to patients, they're making decisions, they need to hear just the important information. Kidney cancer incidence is in the top 10 of male and female cancers, and it's risen over the last decade. The elephant in the room with this is that you can't walk through the ER anymore without getting some sort of scan, MRI, CT, ultrasound, and a lot of times we'll pick up a kidney mass, and most of the patients seen in clinic are because of this. So in 2024, we used to call renal cell cancer the internist tumor because it presented with elevated white blood cells or paraneoplastic syndromes. It's really probably the radiologist tumor these days. I love this study. This study looked at the regional variation of CT scans in Medicare beneficiaries. So they looked at 15 million Medicare beneficiaries. The map here, the red areas are the patients that had the highest amount of CT scans. So patients aged 65 to 85 over a 5-year period, and they looked at 306 different hospital referral regions. They adjusted it for age, sex, race, and smoking risk. And this is a conclusion that you could probably draw without this, but more imaging meant more treatment. More nephrectomies, more partial nephrectomies, more ablations, any renal procedure, right? So for every 182 scans, one additional procedure was performed. When I first gave this talk, when I put this slide in, I was doing it in the UK, so I wanted to show everyone where Madison was. So that's not that's like the Madison-centric view of the US, right? Madison is huge, the rest of everything is small. But you can see Madison actually performed pretty well as far as the risk of thoracoabdominal imaging and the procedures done for kidney masses. This is probably the most depressing slide I have as somebody who treats kidney cancer. So the incidence is going up. This is going up in the 70s, 80s, 90s, but the mortality is not decreasing appreciably. So if we're making a huge difference detecting these tumors, in patients in their 30s, 40s, 50s, incidentally, why is mortality not dropping significantly? So kind of the early summary: detection equals increased treatment. Small RCC incidence is rising. And urologists really need to consider adapting for long-term surveillance, similar to they do in prostate cancer. I have to make the prostate cancer analogy. This is a study by Dr. Kudikoff and Dr. Klotz. Prostate cancer on the right here, kidney cancer on the left. The top blue line is the mass is less than 4 centimeters. Very, very similar survival at 10 years. Kidney cancer, prostate cancer, same or very similar median age of incidence. And really what this lets us think about is, like low-risk prostate cancer, you have to make decisions on individual basis, considering cancer among the patient-specific risks. So we've all made some bad decisions, right? That's not my back. But I think trying to make the best decisions is really complex, right? It turns out even if you have all the information and experts with you, a lot of people don't make the decision that we would think would be the best decision. So when I try to not overload patients, anyone who's been in clinic with me, I usually talk about 2 different studies. And these are the 2 that I think that enable the kidney decision-making. One, so this is Dr. Kudikoff, Dr. Uzo looked at a SEER analysis of locally surgically treated patients, 30,000 patients, and they were all small renal masses. And at 10 years, there was a 5% mortality. So I think this is good because it sets patients' expectations that it's a low mortality, it's 10 years. A lot of times if you say this to a 90-year-old patient, they're like, well, I'm not going to be here in 10 years, right? But it kind of sets the expectations that, the sky is not falling. This is a study from the Disarm registry. There's some newer studies, but I think this has one of the most complete data sets. So about 500 patients who either got initial intervention or active surveillance. The 5-year cancer-specific survival was 100% in the surveillance group and 99% in the intervention group, right? So things are not happening quickly. You have plenty of time to make a decision. Active surveillance is a pretty reasonable choice for most patients. So my initial message when I see patients is, we don't know you have cancer until we have a path diagnosis. There's a really slow natural history for most small renal cell cancers. There's time to consider options and really great outcomes for most patients. It's hard to have better cancer outcomes looking at almost any cancer. All right, making decisions. I got to pick out somebody. Keegan. Let's see. All right, here we go. A bat and a ball cost $1.10. The bat costs $1 more than the ball. How much does the ball cost? Just shout it out. $0.05, right? So when they gave this same question, and this question is used in a lot of books to freshmen in psychology classes at Ivy League schools, about 80% of them get it wrong. So you're in good company. Turns out humans make decisions in a couple different ways. There's a system 1 and a system 2. System 1, as surgeons, we're used to using a lot. It's fast thinking, it's automatic, it's effortless. When you see something, you make that association, oh, $1.10, right? It's something's bleeding, stick your finger on it, fix it, right? For kidney cancer, for a lot of things in clinic, we need to slow down and do more system 2 thinking. Slow, controlled, effort-filled, rule-governed, somewhat flexible. And thinking, okay, hey, the patient's 85, maybe we should watch this, right? And Daniel Kahneman won the Nobel Prize in economics for this back in the 90s. So when patients come in, the data that drives their decisions, and talking to lots of different patients, they want to know, is this cancer? That's the first thing they want to know. A lot of times they've been told by another doctor, especially ER doctors, a lot of times tell the patient it's cancer, they're going to die from it, they have to get treatment next week, right? And a lot of that times that will drive what the patient's thinking. So, Parth, 50-year-old patient, he had a CT for diverticulitis. He has a 9-millimeter enhancing mass. What are the chances that that's cancer? 70, okay. So I made it smaller. It is 50. So less than 1 centimeter is about 50%. This is famous study from Mayo Clinic that looked at, you know, almost 3,000 patients. The smaller you get, the less the chance it is. But we know that we probably are biased in surgical series to operate on patients with higher risk. So if you look at a series of biopsy, the one series out of here and one series out of Toronto, maybe 70 to 74% of patients had cancer, right? Because you're including some patients with less enhancement in there or some more cystic masses. Path size is also smaller than radiologic size because they stick it in formalin. There's less blood in the tissue. So kind of the truth and the number you should remember for anything less than 4 centimeters, about 75% still means 1 in 4 patients probably has a benign or a benign-ish tumor. Worst case scenario, again, patients are fixated on worst case scenario. We know the median survival is about 2 years if you get metastatic disease, but what's the chance of progression if you have so 60-year-old healthy man, 2.5 centimeter renal cell, what's the chance that he dies from renal cell in the next 10 years? Emily, I have to pick on you. 5%, right? So again, remember that number, 5%. And that's why I keep talking on it, because it's, again, you can tell that I'm kind of a half empty type person. It's a 95% chance you don't die from cancer in the next 10 years, right? So that's probably the way, and that's the choice architecture way to frame this. So if, again, going back to the SEER analysis, one of the 2 papers you need to make a kidney cancer decision, the 10-year risk is 5%. Your risk of developing another cancer de novo and dying from that cancer in the same period of time, 7%. Your risk of dying from another non-cancer related death, 24%, right? So you got to keep all those things in mind, especially as patients get older with more comorbidities. So more tests. It's really important to get a high quality dedicated renal mass CT or MRI. Most of the time at UW, we don't have that problem. Sometimes you go out to a smaller place and you might not have the imaging expertise that you need. So what about biopsy for small renal masses? Definitely has some theoretical advantages. You can identify cancer versus benign tumors. You can provide information to guide treatment such as grade, RCC subtypes, and sometimes find aggressive features. Is it safe? This is probably the confidence level is the highest for something like this. The thing that I hear most often, tumor tract seeding. It's rare. It occurs about 1 in every 10,000 patients. Hasn't been reported very much in this century. We look back in this century at UW, we have no patients that have had it. And it's about on par with prostate cancer seeding, which also does happen, but you've never heard anyone say, don't get a prostate cancer biopsy because the chance of seeding, or that's rare. No one discusses that. This is Tasha Pashelsky when she was here, looked back through 1,100 patients. Again, the major complication rate was 0.4%. We have our radiologists are willing to do this on patients who are on aspirin, who had an INR up to 2, or had low platelets, down to 25K, was not increased for those patients. The biggest thing is the non-diagnostic rate. It's about 15%, right? And so that's just where we miss. If you look in all big series, the non-diagnostic rate, somewhere between 15 and 20%. Really depends on how you define it. I define it as any insufficient tissue, necrosis, fibrosis, or if you just get benign kidney. A lot of the other series, if you see lower rates, it's because they consider benign kidney as diagnostic. I think if you don't get a benign tumor, the information is not relevant. So just to look at the accuracy, it is accurate to predict the cancer presence. The histologic subtype, also accurate, not accurate to really predict tumor grade. And here's 2 non-scientific observations about renal mass biopsy. It definitely improves informed consent. Patients may change their treatment if they know that they have cancer, especially if they know they have a high-grade cancer. They may decide to not do surveillance. Conversely, if a patient finds an oncocytoma or renal oncocytic neoplasm, they may decide to do surveillance. It really requires an institutional commitment. It requires your radiologist to do this quickly. If you don't do it quickly, you're not going to be able to get patients to do it. Patients don't want to wait 2 months to get a biopsy and come back. There's a sense of urgency. There's a sense of I need to get this done soon. So this study we presented at the AUA in 2018, we just looked at 100 consecutive patients with small renal mass, and they were given a survey before and after their initial patient visit. We had them just do a visual analog scale and rank how nervous were you about your renal mass diagnosis. It is really interesting. Almost half the patients ranked this diagnosis among the most stressful times in their life, which is amazing, right? That was kind of a shocking to me. I thought it would be less. A lot of these patients were like patients who had had a liver transplant, and it's still one of the most stressful moments of their life. It's something to think about because we don't make great decisions. You need a little bit of stress to make a decision, right? You need to be awake. You need to be knowing that like this is important. But when it's the most stressful moment of your life, you have to back up and slow down. We also asked patients if they would want a biopsy. About 84% of patients said that they would consider a renal mass biopsy or that they wanted to know the information. Only about 42% of patients actually received a biopsy. And a lot of those patients were patients pre-ablation. We were talking a little bit about it yesterday. A lot of young patients, we don't see a whole lot of reason to do a biopsy. And in older patients, a lot of times we won't do a biopsy just because to minimize the intervention. So the most common argument against biopsy is that it's not going to change your management. I agree in young patients or extremely comorbid patients, like we were saying, but that's not most patients. Again, the median age of diagnosis is 64. So patients 65 and older have a lot more comorbidities. Those are a lot larger percentage of patients. So we should think about this. This is probably the biggest, and I just pulled a paper randomly out of the past. I'm not picking on Dr. Gill, but if you look at oncological outcomes in here, the percentage of patients with benign pathologies between 17 and 24%. So instead of doing off-clamp partials on everybody, maybe just don't operate on people who don't have cancer and you'll solve the problem of, right? So biopsy has decreased in some places, and here we're at single digits, 7 or 8% a year, and those are mostly young patients that we operate on that don't have cancer. So we think about shared decision making. It's a buzzword. We talk about it a lot. Again, the patient's coming in, they're thinking, is this cancer? What's the worst case? Can you fix the problem? Are there other tests? Do I need, how quickly can I get treatment? The urologists were all, thinking, okay, what is the treatment with the best cancer outcomes that preserves renal function with the least morbidity? But we also need to think, will the patient benefit from treatment at all? And again, that's where we got with prostate cancer over the last 20 years, but that's probably where we need to be with kidney cancer as well. Okay, so again, back to behavioral science. This is the argument for dilution. Good example for dilution. So my daughter comes in the morning, she's like, Dad, I got a sore throat and I'm not feeling great. I don't feel like I can go to school today. And my elbow is kind of itchy and my, leg's not working right. I'm kind of tired. There's no test tomorrow at school. The more you say, turns out, weakens your argument, right? So especially when you're first coming out into practice, I remember I wanted to tell every patient how much I knew about kidney cancer. So I'd just be spitting out all kinds of information. It doesn't help. This is a great TED Talk Dr. Sivanathan gave, and this is a great article in Nature Human Behavior. Anyone who's watched anything on TV in the last 10 years knows there's lots of drug commercials, right? So they just had two groups. One group had side effects may include dry mouth or throat, headache, uncontrollable shaking of the body, and mental problems with attention. They heard the whole list. The other group heard side effects may include uncontrollable shaking of the body and mental problems with attention. The two biggest, right? Turns out there was a statistically different difference in whether or not patients would rate those side effects as severe or not based on how many they heard. They were also more willing to take the medication and willing to pay a higher price if you just listed more side effects, right? So that's why you hear, side effects make you blah, 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 right? That's why they're going on because they're diluting their effect. This also is a cue to me to not dilute the effect of this talk and to keep going here. So 2016, AHRQ published this meta-analysis of diagnosis and treatment for small renal masses. No larger randomized trials. Nothing has changed in the last 10 years. The only reasonable outcome from any of this is that radical nephrectomy is worse than partial nephrectomy or ablation for renal functional outcomes in small renal masses. Duh, right? Sorry, I've got teenage daughters, but you know that, right? There's no data to show that, cryo is better than microwave, is better than RFA, is better than partial. There's just not the data. It's not that we don't, that there's not a difference. We just don't know. The data's not there. This is a study that came out of the Mayo Clinic, in which the authors say that they think that all T1 renal masses have equivalent outcomes if you get partial nephrectomy, RFA, or cryoablation. Their 5-year cancer-specific survival was 99, 96, or 100%. But if you look a little bit more into the details, I think this projects pretty well. The benign rate for patients who got partial was 21%. For RFA, it was 33. 26% weren't biopsied. The benign rate for cryoablation was 35%. If you put all those numbers in, it's really hard. You're not really comparing apples with apples. And again, if you look at their Kaplan-Meier, you're looking at, the number at risk at 5 years is only 39 patients for patients who got RFA in this. It's really hard to say they're equivalent. I don't think that they're equivalent, but the bottom line is we just don't have that data. And I'm not sure we ever will have that data. One thing I can say for sure is that you should get a biopsy prior to ablation. So if you do ablation, you destroy the tissue. You can't get a biopsy afterwards. If you look at these are the 4 biggest studies that I could find with on ablation. And if you look at the non-diagnostic rate or the oncocytoma rate, somewhere between 15 and 45%. I mean, this study, Atwell et al. Out of Mayo, 45% of the people that they ablated didn't have cancer or they didn't know that they had cancer, right? So it's hard to follow those patients afterwards, 10 years afterwards, 5 years afterwards. And so get the biopsy beforehand. Local recurrence, definitely more common in thermal ablation. You can make, one of the reasons they make makes the guidelines is because you can get a second treatment and, that 5% more or that 10% more that have local recurrence usually are treated without any problems. Usually you don't have to do surgery on those patients. So kind of the summary for thermal ablation studies, many of these studies consider small renal masses rather than biopsy-proven renal cell cancer. They probably overestimate the cancer outcomes. Ablation for many years was preferentially selected for older, sicker patients and smaller, lower grade tumors. So if you had a higher grade tumor, you took that patient to surgery. So you're not really, again, comparing apples to apples. Definitely a higher local recurrence rate versus surgery, but a similar cancer-specific survival and metastatic rate. You can summarize the active surveillance data very similarly. Biopsy-proven RCC is rare in active surveillance studies. It was between 10 and 20% in the DISARM study. Patients are selected for surveillance because they're older and sicker. So it's really difficult to evaluate RCC progression because patients die from other causes before they can die from RCC. So you don't really know what the true mortality is. There's no studies with long-term follow-up, but an initial period of active surveillance is generally safe. It is an unqualified, especially if you have the 2 centimeter mass or lower in our current guidelines. So in a perfect world, maybe, in medical school you're taught, randomized trial, maybe we would develop a randomized trial. The endpoint should be survival, right? Maybe cancer survival, maybe overall survival, but you have to randomize it because a lot of these patients have competing causes of death, patients over 65. So maybe you start just use round numbers, 1,000 patients treated with surgery, and then 1,000 patients treated with X. Maybe we'll make it SBRT because we have that journal article later. You have to follow the patients for 10 years because we know that in the first 5 years, very little happens, right? Surveillance, about 100% survival. And then if SBRT is 20% better than surgery, you expect only the difference in the patients that died to be about 10 patients after 10 years in a study with 2,000 patients. I don't think we're ever going to do this study, but this is just putting it out here because this is what you would need to probably prove that something is 20% better. Some people will say this study has already been done. This is a prospective randomized ERTC study looking at partial versus radical for patients with 5 centimeter tumors or less. They had 45 centers. They did it over 14 years, only accrued 541 patients. They closed the study for futility. The median follow-up was 9.3 years. 3.9% patients progressed to metastatic disease, and only 2% of patients died of renal cell cancer in that timeline. So again, this is kind of proving that it's very difficult to do, probably will never be done. So as a urologist, what's the best treatment for small renal masses? Patients who are young and larger tumors, surgery. You can do ablation, up to about 5 centimeters at experienced centers. Renal function, partial or ablation are very similar. Procedural morbidity, ablation is definitely easier. A lot of those patients leave the same day. It's hard to deny that. Same thing with morbidity for ablation is a little bit easier. But then really what you have to ask is, does the patient need treatment? Again, if you think about radiation or surgery for prostate cancer versus watching the patients, we probably should be watching the patients more. And we need to adapt our clinics to do that, right? Because a lot of times surgeons are wanting to see a patient and operate. We probably need to follow these patients more. So this is one of the first few years I got to Wisconsin. These are my older daughter's ice fishing. I think this was the second time I've been ice fishing. But the look on my daughter's face when she caught this tiny little fish, it's kind of like the look on Dr. Scherer's face when she cut out her first partial, like so proud, right? And did a great job. But we really should be looking for bigger fish. It's these small tumors in older patients really don't seem to be impacting how mortality will be in the future. And I think that's something that we need to think about. If I can leave you with one closing thought, really you should try to be a cancer doctor who does surgery, not a surgeon who treats cancer patients. I think the more you think about the cancer, the more you own the disease, the better you can provide that service to the patient. Because we know a lot of these patients do better without surgery or ablation or any treatment. Thank you.
Great talk, Dr. Abel. Any questions from the audience or online? Okay, we've got one from the online gallery. I can read it. Okay, Dr. Best says, given the low morbidity of biopsy, how many % non-cancer path specimens in younger patients would you need to see to recommend biopsy? Why not biopsy? Bit of a long question. Why not biopsy them too?
Yeah, so that's a really good question, and something that I know Dr. Das knows quite a bit about. But so the top two benign renal masses we see are renal oncocytic neoplasm. They used to go ahead and call it renal oncocytoma. These days, the pathologists have decided that they don't get enough specimen on the biopsy, so they're just going to put it all into one big wastebasket term that includes renal oncocytoma, includes chromophobe renal cell, includes some eosinophilic renal cells. And so it's created a lot of confusion, and we don't know how to follow those patients. So if you get a patient that's 45, we followed lots of patients, for 5 years or more with oncocytic neoplasms. We haven't followed patients for 20 or 30 or 40 years. So a patient comes in, 30, 40-year-old patient, it's hard to follow them for oncocytoma, just quite frankly, because we don't have that data out for years. You certainly could biopsy. Sometimes we find patients with a lipid-poor AML. It's like hitting the jackpot because we know that patient does not need treatment. With renal oncocytic neoplasms, there's still a risk. It's a very small risk, and those patients should be preferentially followed, but it's really hard to do that in practice.
Yeah, so Jason, terrific lecture, obviously, sort of state of the art. So I had a question and a comment. So the question is, why don't you or a group undertake this important study. Hein von Poppel, who I know, presented this paper, I guess over a decade ago. So it's overdue, number one. Number two, as you well know, better than anyone else in the room, that the study was highly flawed. On the other hand, I think we're in this business to get it right. And if you think about a 10-year study, I think based on current technology, which is different than in the early 2000s, I think the study was conducted, right? It started about 2002, I want to say, or 2001, and was completed ultimately and then published. But I think we have better data sharing, for instance, today. So I think it's a very valid study, and people will be interested. And what I noted when von Poppel presented this paper is he was highly criticized, and there were many editorials and so on. But I think that's the sign of a good study, because that means you're getting into people's cheese, and it's just like the paper we wrote, Chris Haas first authored, had 3 editorial comments, because the thulium laser people were very upset that it wasn't better and so on and so on. So, I think the point is, sort of practice changing or paradigm changing studies have value, great value. So I would just have you think about it. And of course, comment. But my comment, it's an interesting one, because obviously, again, super high level, talking about negotiation and human behavior, which I think are very important. And the only place I diverge from you a little bit is the idea of saying less. So I agree that if I'm negotiating with you to do something, sure, I want to lay low on giving you too much information. On the other hand, like true shared decision making, I'm okay giving you more information, or excess information even, and a lot of that's a judgment call. And the residents know when they're with me in clinic, sometimes they'll say virtually nothing, but that's usually because they've said everything. And then other times I'll just give way more information than the patient wants, but somehow I feel like it might be helpful. So I think first I'd like your opinion on doing the big study, because I think this is an opportunity if no one is undertaking it, and I thought someone might have been. And then 2, sort of what's your take on sort of true shared decision making and the need to give out information?
So those are obviously excellent comments and questions. As far as the being able to study small renal mass outcomes, I think it's difficult because there's less of a funding source. We, with UVA and UCSF, we recently got an R01 to study this exactly. So we're going to be collecting outcomes for patients back 20 years, and then prospectively also looking to see if we can use this data, provide it to patients to help them make decisions. I think that will be helpful. I think it's hard to get anything randomized and prospective, but I think we can get things prospective, just because patients don't want to be randomized to surgical procedures, so it's difficult to do. But I think it would be amazing if we could do it. I think patients would possibly be randomized to doing 2 different ablation modalities. But again, I don't think that's, maybe the ablation companies would not, pay for that or be interested in that. But that's something we could do. Your comment about providing patients with less or more information, I completely agree with you. I think during that initial discussion with patients, when you walk in the room and they hear or they see the mass, it's like a movie. It's like watching a war movie where they throw the grenade and then all of a sudden, like they don't hear anything else. Like all they hear is they have cancer. They don't hear very much else from you, right? So I think providing them with the key information in that setting is my number one goal. Now, I want them to come back and I want them to, give them resources so that they can look up things and be better educated, because I think better educated consumers, patients are the key. And I think developing that patient education and developing the relationship is obviously, key to having a good, the best outcome for that patient, because the best outcome is not the same for everybody. Some patients are, smokers. If I could get them to stop smoking, it'd be better probably for them than taking out their small renal mass, a lot of these patients, right? So again, there's a lot of different modifications of things that we can do. I completely agree with you, giving patients information, though, in parcels. And some patients come in, they've read more, they've read your studies, they want to critique, why didn't you do this? Why did it, so I think, patients are all a little bit different that way.
Great, really enjoyed the talk. I had a question about this issue of ablation, re-ablation, and I know it wasn't sort of a central tenet, but there's been this thought that, oh, we can just re-ablate it, they'll do fine. So I guess the question is, if you begin to look at long-term outcomes, has anyone published anything, looking at 5, 10 years down the road? Because I worry a little bit about prostate. Now, again, prostate's different, it's multifocal, but I'm just wondering in the kidney realm, do you just make these cancers mad?
Yeah, I think occasionally the answer is no. So the straight answer is no. A lot of times ablation was used, 10 years ago, especially just for patients who were very sick and older. So they didn't live long enough to have some of those complications, right? I think that would be an interesting study to look at, but I think it's difficult with the data we have. We could probably do it at UW, though.
Yeah, or maybe pull it out of some data set.
Mm-hmm.
Really be
Yeah.
Anecdotally, that have died, just have died of, I don't, number one, a number of them died. Two, I can't remember any. That's a highly selective. Those people. Like, perspective, a good number of those patients never. So, there are no other questions I have. Wait, I'll give
Dan, no, Dan's got a question. Dan, we've got time. I mean, yeah, let's take Dr. Shapiro's question. Hot mic over there.
Yeah, I obviously a fantastic talk. I really like your analogy of the like small fish versus big fish, but every big fish at one point was a small fish. And so I think the issue with the small renal mass is our fear of the future about, you've got a borderline 3.5 centimeter renal mass, 65-year-old who's like sort of comorbid, but probably going to live a while. And our biopsy can only tell us so much. The grade is notoriously unreliable. So we don't know which of those small fishes is going to be a big fish. And so my question for you is, how do you see the field moving forward in terms of more advanced techniques of identifying these potentially hazardous fish?
Yeah, no, I think it's an interesting analogy, right? Because you don't know what's going to become bad in the future. What you do know is the ones that grow have a higher metastatic potential, right? So if you can talk that patient to initial period of surveillance, it's reasonable. I also think it's reasonable to take that out where we are right now with the current data, and that's a very individualized decision. That's like a heart to heart, like hey, but it's again, that's difficult when that patient is super comorbid, like has performance status of 2, walks in like you're getting like third-hand smoke exposure, and you're like, hey, doing this surgery is not on your top 10 list of problems, right? So I think that's something that we really have to keep in mind. And I know you do.
Yeah. So again, obviously, great topic and discussion. So the first thing I'd say is usually, so this is for the residents, usually randomized trials are the best studies. They're not always, right? And often some of the best studies in history have been case reports. But RCTs are very valuable, and I think the NIH they're beginning to figure this out. And I think you said it a couple times, Jason. Doing this study would be hard. And that's right. That's why no one's done it. But, I think when we have undertaken RCTs, which is probably 5 or 6, so that's not many out of however many publications I've had. But they're, except one, they were all very impactful studies. So I'm still making the case. The other thing that I've changed to, which may be a thought for everyone in the room, is you mentioned worst case scenario and that patients are worried about worst case scenario. Like I would lead with best case scenario. So, and maybe that will change their thinking to say best case scenarios is we do nothing and you die of something else. That's best case scenario. And in point of fact, the chance of that's 95%. Now, do you want to talk about the other 5? Sure, happy to. So I think it's an interesting thought, and you're right. I think the people that are going to bite on the worst case scenario are still going to bite on the worst case scenario. But maybe the people in the middle will be interested in the best case scenario. And I think the thing I've seen, when I've been out and watching others is, people are highly influenced by everything the doctor says and does, down to the expression on your face. So it's just a thought. What are your thoughts on that?
No, I think those are great, and that's choice architecture in motion right there. I mean, that's exactly what I was saying earlier as far as, if you walk in, you guys and girls have so much power. When you walk in, if you tell the patient needs to come out, they're probably going to do it. If you say this is the gold standard treatment, you could go with the silver or the bronze standard treatment, but I would go with gold, right? Like nobody wants that. What you lead with, what your expressions are, if you look dire, they pick up on that, right? I think those are, amazing points, and it's something you can take beyond kidney cancer. You take it to any patient interaction you see. If you want them to do something, you recommend that to them, but you have to really be honest to yourself. Are you recommending something with a lot of certainty that's going to benefit them? It's much easier to make a decision for a large renal mass or a cystectomy. Hey, you've got muscle invasive bladder cancer. If we don't do this, things are going to be bad than it is for a small renal mass or a intermediate risk prostate cancer where you're like, well, if I knew the day you were going to die from prostate cancer and the day you're going to die from something else, then I could tell you what to do. But otherwise, we're just kind of guessing.
All right, I think we'll end there. Great discussion, and we'll take a couple minutes to transition to a journal club, which Dr. Shapiro will be hosting today. Thank you.